Very good evening to one and all. And today the topic for my debate is low volume interscalene block for shoulder surgery. Yes. The flow of information for my presentation is as follows. First, I'm going to discuss why we are depositing local anesthetic in the interscalene groove for shoulder surgery. Then, if you are doing so, what is the concern? If there is a concern, is there anything that we can do to reduce the risk? And then fourthly, if I reduce the risk objectively and consistently under the ultrasound guidance, what is my conclusion? So this is how I'm going to flow through. To understand why we are injecting local anesthetic into the interscalene groove for shoulder surgery, first we have to understand the innervation of the shoulder. Coming to the dermatome, the nerve supply for the skin comes from two nerves. One is supraclavicular nerves and another one is an axillary nerve. The supraclavicular nerves comes from the superficial cervical plexus. The root value is C3, C4. Leave out that the brachial plexus provides skin supply through axillary nerve. The root value is C5 and C6. So if you look at the dermatomal supply from brachial plexus comes from C5 and C6. Coming to the myotome, the muscles are all about rotator cuff muscle. There are 5 muscles, 3 from behind, 2 from front. The 3 muscles are supraspinatus, infraspinatus, teres minor. Subscapularis and teres major is from the front of the scapula. So the supraspinatus and infraspinatus takes its nerve supply from suprascapular nerve. The root value is C5, C6. The 2 muscles in front, subscapularis and teres major, takes its supply from subscapular nerve, upper and lower. The root value is C5, C6. And then the top muscle, the deltoid and teres minor, takes its nerve supply from axillary nerve. The root value is C5, C6. So that means the myotome supply to the shoulder get its innervation from C5, C6. Coming to the osteotome is formed by 2 bones. One is upper end of the humerus and glenoid from the scapula. If you look at the front view, the upper end of the humerus is supplied by the axillary nerve, whereas the scapula and the glenoid is supplied by the subscapular nerve. If you look at the posterior aspect, the upper end of the humerus and the glenoid supplied by 2 nerves, that is suprascapular and long thoracic. Here also the root value is C5, C6 for these all the 3 nerves. So the osteotome also comes from C5 and C6. To sum up, I wanted you to understand one thing. The shoulder joint receives innervations from 7 different branches. All these branches are arising from different parts of the brachial plexus, some from the roots, some from the trunk, some from the cords, and some are terminal branches. But one thing common to all of them are all these branches receives fascicles from C5 and C6, and both these roots are confluents to form the upper trunk. So if you ask me, so that is why I painted in green color so that you can understand all the branches that goes to the shoulder joints are receiving fascicles from upper trunk. So if you ask me what are all the 2 nerves that I will target for complete shoulder analgesia, I would say it is C5 and C6 nerve root. Then if you ask me what is the one target that you wanted to focus for complete shoulder analgesia, I would say upper trunk. As you all know that in the interscalene groove, C5 and C6 combine to form the upper trunk. So we are injecting the local anesthetic into the interscalene groove to block these nerves. But unfortunately, when we are attempting to do, the local anesthetic from the interscalene groove can diffuse either directly or across the scalene muscle to reach the phrenic nerve. It can produce phrenic nerve palsy. Suppose if your local anesthetic volume is more and the local anesthetic migrates even more medially, it can block the sympathetic chain over the longus colli muscle. Suppose your local anesthetic migrates even more medially, this brown structure is esophagus, this white structure is trachea. In the tracheoesophageal groove, it can block the recurrent laryngeal nerve and produce hoarseness of voice. There is a cut section at the same level to depict what happens in the cut section. This is the interscalene groove. This is anterior scalene. This is middle scalene. These are all the brachial plexus elements. When you inject the local anesthetic, it can seep on the anterior surface to reach the phrenic nerve, or it can diffuse across. From there, if it migrates medially over the longus colli muscle, if it comes, it will block the sympathetic chain and produce Horner syndrome. If it migrates even more medially to the tracheoesophageal groove, it produces hoarseness of voice. These are all the complications of the interscalene block. Now, what we can do to reduce the risk? It's very simple. Prevent the local anesthetic reaching these targets. And for that, how we can do about, we have 3 steps we can implement. One is move away from the phrenic nerve. That is the first one. And then second thing is reduce the local anesthetic dose that is just required to soak your target, not phrenic or any other structures. And the third thing is precisely deposit the local anesthetic dose into the target. So now let us see one by one all the three steps, how we can do about it. Move away from the phrenic nerve. If you look at, this is the anterior scalene muscle and this is the middle scalene muscle and these are all the trunks. You can see the phrenic nerve runs from the lateral to medial. This is C5, C6, C7, C8 and T1. C5 and C6 joins to form the upper trunk. C8 middle trunk, this is an inferior trunk. You can see the suprascapular nerve takes off from the trunk. So if you look at just by eyeballing itself, the roots are very close to the phrenic nerve and the trunks are little away and the divisions are far away and then the cords are much away from the phrenic nerve. So the correspondingly the incidence of phrenic nerve is decreasing. 100% it is in the interscalene groove, 50% in the supraclavicular area, and it is about 5% in the costoclavicular area. So now the second task that we can do is reduce the local anesthetic volume. If you see in this cadaveric image, this is the anterior scalene muscle, this is the middle scalene muscle, this is C5, C6 and C7. C5 and C6 forms the upper trunk and the phrenic nerve lies over the anterior. 10 to 20 ml of local anesthetic, you are going to flood the entire neck and there is no way your phrenic nerve can escape. So what we have to do is we have to find a local anesthetic volume that is adequate enough to soak the upper trunk. If you can do that, that is really great. Now, how to do that? If you look at in this is an anterior scalene muscle, this is the middle scalene muscle, and this is the C5 and this is C6 joined to form the upper trunk. The black ones are the fascicles and the white ones are the connective tissue. This is the middle trunk. And the needle is approaching from the anterior medial to the lateral. This is a 25 gauge pinky needle. If you look at, I am carefully navigating the needle tip between the fascicles into the connective tissue and injecting small aliquots of local anesthetic. Small aliquots mean 0.2 to 0.5 ml at a time, so that and allowing time for the local anesthetic to diffuse. If you look at even in the microanatomy, you have a clear-cut space between the fascicles with a good amount of connective tissue. So when we inject like that, what we find is, I am scanning after the post-injection. If you look at the local anesthetic well soaked to the upper trunk divides into anterior and posterior division. As I scan back, it unites together, and as I scan more, it divides into C5 and then C6. As we go down, it divides into anterior and posterior division. This last corner was the suprascapular nerve. So now how much to inject? In a targeted truncal injection block, we found the minimum effective local anesthetic volume for a truncal block is about 4 ml per trunk. Suppose if I inject 5 ml of local anesthetic, what will happen? How long my block works? The duration of surgical anesthesia and analgesia. In a study looking at the selective injection of the supraclavicular nerve and the upper trunk for a clavicle procedures, we injected 3 ml into the supraclavicular nerves and 5 ml of equal mixture, that is 2% xylocaine with adrenaline and 0.5% bupivacaine. When we injected, we found selective blockade of supraclavicular nerve in the superficial cervical branches. And in the brachial plexus, we blocked only the suprascapular nerve, axillary, and the musculocutaneous nerve, which are all arising from the upper trunk, whereas median radial ulnar nerves are completely spared. If you look at, with this volume, 5 ml, we had a surgical anesthesia for about 2 hours and analgesia for 5 to 6 hours. If you look at the pre-block, the shoulder joint is completely intact. The axillary nerves are intact, and then elbow flexion, the musculocutaneous nerve is intact, median radial ulnar nerve was on completely intact. After 15 minutes of post-block, this is the extent of sensory anesthesia that we got. And then the shoulder joint, the axillary nerve is 0, the suprascapular nerve is 0, musculocutaneous nerve is 0. And if you look at the median radial ulnar nerve and then the finger movements are completely intact. This is the radius where the patient can effectively extend his wrist. There is a little bit of weakness on the supination of the hand. But if you look at all the finger movements and the hand grip are full. So this is opponent's median nerve, all the finger flexions adduction of the fingers and abduction of the fingers. So now what about the phrenic nerve involvement? None of the 70 patients showed any signs and symptoms of diaphragmatic paralysis, even though some of the patients having multiple refractures and COPDs, but we don't have any objective data. Prospective study with diaphragmatic function as a primary outcome is underway. I think maybe in 2021, PRAC, we may have some clarity on this subject. So now to sum up, whether the ultrasound can show the targets that we understood, will it show all the critical structures? If you see in this video, this is C5, C6, this is an anterior skeletal muscle, that is the middle skeletal muscle, this is C7, this is vertebral artery. And if you look at here, this is the phrenic nerve on top of the anterior skeletal muscle. Whenever your local comes from here to here, it blocks the phrenic nerve. And from there, if it migrates medially, this is the longus colli muscle over the C6 transverse process. On top of the longus colli muscle, if you look at this hyperechoic structure, is the sympathetic chain. When your local comes from here to here, it blocks the sympathetic chain and produces a Horner syndrome. Suppose if your local anesthetic migrates medially, this is the esophagus and this is the trachea. This hyperechoic structure at the tracheo-esophageal groove is the recurrent laryngeal nerve. If your local comes out here, it produces hoarseness of voice. So now, when the ultrasound, to conclude, when the ultrasound shows not only your target, where to put your local anesthetic, it also shows what are all the areas you should not deposit your local anesthetic in a real time, so clearly and objectively. When such a possibility and privilege is having in front of us, still referring the brachial plexus with respect to anatomical landmark is not justified. So I just changed the terminology from low volume interscalene block for shoulder surgery to low volume upper trunk block for shoulder surgery. So I'm sure if I inject 5 ml of 0.5% BPOK, and as I shown in the video, definitely I would produce 5 to 10 hours of intense shoulder analgesia without significant phrenic nerve involvement. And for me, low volume upper trunk block for shoulder surgery is a big S. Thank you very much for your kind attention. Thank you.